The Ohio Psychological Association's Education Committee would like to welcome you to Insurance Basics, Essential Information for Starting Your Practice, a virtual workshop presented as part of our 2021 annual convention. OPA is an approved CE sponsor of the American Psychological Association and maintains responsibility for the program and its content. OPA is also an approved CE provider of the Counselor, Social Worker, and Marriage and Family Therapist Board of Ohio. This session has been approved for 2 continuing education credits in ethics. Instructions on how to receive CE credit will be covered at the end of this workshop and are available on our website at www.ohpsych.org. At this time, I'd like to introduce our speakers. Dr. Jim Broyles is Director of Professional Affairs at the Ohio Psychological Association. He has been a member of OPA since 2002. He has served as Finance Officer, President, Insurance Committee Chair, Marketing Task Force Chair, LGBT Committee Chair, and has been a member of numerous committees over the years he's been involved with OPA. He currently co-chairs OPA's Leadership Development Academy. Dr. Broyles has a practice in Grove City, Ohio, just south of Columbus, and specializes in working with children, adolescents, families, and LGBT issues. Dr. Virginia Fox Clark is a clinical psychologist who provides treatment to clients of all ages with a specialty in the assessment and treatment of children and adolescents. Areas of practice include depression, anxiety, including obsessive compulsive disorder and panic disorder, behavioral and developmental problems, including trichotillomania and ADHD. Other areas of practice include treating adults with depression or anxiety, coping with family members with alcoholism or addictions, and women's issues. She also performs evaluations for gastric bypass surgery, memory problems, child custody, intellectual and achievement assessments, and personnel selection and consultation to businesses, government, and safety forces. Evaluations performed for documentation of disabilities for schools, college, and college entrance exams. Dr. Clark received her PhD from Miami University of Ohio and belongs to both the Ohio and American Psychological Associations. She has been the president of Western Reserve Psychological Associations, Inc. for 4 years. Since 2015, she has been on the Insurance Committee. In 2017, she became chairperson of the Insurance Committee. Dr. Leslie McClure earned her degree in clinical psychology from the Chicago School of Professional Psychology and her undergraduate psychology degree from Skidmore College. She completed her postdoctoral fellowship training in geropsychology at Summa Health System in Akron. She is currently the owner and clinical director of Kent Psychological Associates, an outpatient mental health clinical practice in Northeast Ohio. Dr. McClure's areas of clinical interest include working with individuals with chronic illness or pain and working with the geriatric population. In addition to psychotherapy, she also conducts cognitive assessments of memory complaints and pre-surgical psychological evaluations for bariatric and chronic pain surgery candidates. Dr. McClure pursued group practice ownership with the primary goal of creating a healthy work environment. Throughout her education and career, she has pursued additional learning opportunities in industrial organizational psychology and strives to apply IO psychology principles that increase workplace engagement and prevent burnout. Now it's my pleasure to turn over the workshop to our speakers. Welcome.
My name is Dr. Jim Broyles. I am the Director of Professional Affairs for the Ohio Psychological Association. My primary role with the association is to help our members with insurance issues. And so that's an important part of what we're going to be talking about today. I'm being joined by Dr. Virginia Clark, Dr. Leslie McClure, who also play really important roles in helping our association with insurance issues. Dr. Clark is the former chair and Dr. McClure is the current chair of our insurance committee. So the purpose of our workshop today is to give just some basic basic background information about working with insurance. So our idea here is that there are many very well-trained behavioral health professionals who are very knowledgeable about a lot of different areas, but don't have a whole lot of understanding of some of the really important basic ideas with working with insurance. And those same people see that lack of knowledge as sort of a barrier to moving more into the private practice world. So that's our intention today, is to talk about those basic concepts a little bit more and to sort of give you an introduction or get your feet wet with an understanding of the insurance world. Before I get started, part of what I want to do is talk just a little bit about private practice, because moving into the private practice world is very relevant to some of the insurance ideas that we're going to be talking about. So our entire healthcare delivery system has changed considerably in recent years, and it continues to evolve. These changes are driven by federal law, such as the Affordable Care Act, as well as the policy and practices of the Center for Medicare and Medicaid Services and individual private health insurance companies. In the past, many psychologists and other behavioral health providers have preferred to provide their services through solo practices. And when I say solo practices, I mean a single provider in a single office or a single business, providing their services in that way. For many reasons, including increased costs of operating a practice, group practices are quickly becoming far more sustainable and practical. And the reality is many insurance companies are showing increasing preference for contracting with groups, and this trend will no doubt continue. So if you're not in the private practice world so much right now and you're thinking about entering into that, then I urge you to consider looking at different ways that you might be able to either become a part of a group practice or start a group practice, because it's much more sustainable for the future. So I want to talk to you, just getting us started here, a little bit about managed care contracts. And this can be like sort of a confusing idea for a lot of people. Most insurance companies, as well as Medicare and Medicaid entities, provide coverage through the framework of what is commonly termed managed care. So this essentially means that the entity in question, the company or the insurance provider in question, maintains a network of behavioral health providers with whom they have a contract. So even with Medicare and Medicaid, there is some form of agreement that you agree to operate or abide by their rules. So the contract for nearly all of them stipulates rules for interacting with their insureds. Diagnosis covered, reimbursement rates, whether or not and to what degree services are covered. So clients often have separate sets of benefits for receiving services from a contracted provider, and that's called in-network, versus receiving services from a provider who is not contracted with that entity. That's termed out-of-network. So once you as a provider agree to sign a contract with an insurance company, then you're agreeing to operate or abide by their rules. And at that point, the way that you interact with any person who's insured by that company who comes into your office, the way that you interact with them is guided by this contract that you sign. So it's a good idea to think about how contracts can often differ across professions. So, for example, Medicare contracts with psychologists and master's level social workers. They don't really contract with clinical counselors or marriage and family therapists. A lot of times I'm asked about, why, insurance companies and other entities make the rules that they do. And I always say, I really don't know. My main role is to help sort of interpret these rules and let you know what those are. But why they just contract with these two professions, but not others, I certainly don't know. But that's a difference with interacting with Medicare. Most insurance companies reimburse more slightly per service for psychologists versus other independently licensed professionals. And sometimes that difference, isn't really huge. But that's one thing that we will often notice across the board when comparing profession to profession and the contracts that each gets. Reimbursement rates that are, established in the contract will also vary by geographic region. And that's even true of Medicare, actually. So, the actual rate that you received can vary according to what part of town you're in, where you are in location in the state. Sometimes it can even vary according to area of specialty. I think for the private insurance companies, they operate a lot by the ideas of supply and demand, and they think there's a greater demand for a particular area of specialty or geographic location. They reimburse for that. They also will reimburse for cost of living differences in in specific geographic locations. So I want to talk a little bit about advantages and disadvantages of having a contract with an insurance company. So the advantages of contracting with an insurance company will include things like you have a much larger availability of clients. There are many people who really can't afford to seek or receive behavioral health care. If the cost is too high, they really have to operate within their plan and using their insurance in order to be able to afford it. That's very, very much like, healthcare, physical healthcare. You can receive direct referrals from the company. So sometimes people will say, I need to go to someone who's on my plan. Let me look up my plan and find out, who I can go to see. Or sometimes people will even call their insurance company, and the insurance company or the EAP will guide them to a particular provider because they're in network. Disadvantages of contracting would include there's a restriction on the reimbursement rate that you receive. Typically, behavioral healthcare providers will receive lower reimbursement rates from an insurance company than they typically charge out of pocket. There can be a restriction on the services offered. So once a provider signs a contract with an insurance company, then they make that agreement that they are only offering certain services, but then not others. And then, of course, there are some very strict record-keeping requirements and potential audits, and these two things go hand in hand. So in other words, record-keeping requirements for psychologists and social workers and clinical counselors are typically guided by a number of different sources. So in other words, their licensing board will make some certain more general requirements for record keeping, but then the insurance company that the professional signs a contract with will give many more specific requirements for keeping the records. And then, of course, often, I shouldn't say the word often, what can happen is that particular insurance entity, Medicare or the private company, may say, hey, we want to take a look at your records, and that's called an audit. And then they want to make sure that you're keeping your records in the way that they prescribe, that they're requiring of you. So advantages of not contracting with an insurance company would include that you have a much greater freedom to set your own fees, right? So you can charge what it is that you want, or what feels right for you for the services that you're offering. There are fewer limitations on the services offered. So the kinds of procedures or services that you use, the kinds of diagnoses that you treat, you're not being restricted by some of the restrictions that insurance companies require, when you sign a contract with them. Disadvantage of not becoming involved or not signing a contract with an insurance company would include that you just have a much more limited pool of potential clients. Again, going back to that idea that so many people can only afford to seek behavioral health services if they go to someone who's on their insurance plan to ask their insurance to help pay for that. And so now I'm going to turn this over to Dr. Clark, who's going to be talking to us a little bit more about electronic records and billing.
Well, thank you for the opportunity. An essential part of interacting with insurance companies is establishing the right record keeping and billing system. In the past, psychologists were able to maintain their relatively smaller practices by billing insurance companies through mail or even fax. Services were documented through paper records. Changes in our healthcare delivery system have made electronic billing and record keeping essential. Many software companies now offer software and internet-based packages designed for behavioral health practices, which keep records of services and interface directly with insurance companies for billing the resulting claims. After the initial setup, these allow for quicker, easier billing and reimbursement with nearly all insurance entities. And having been an owner of a group practice where we did this a year ago, I am eternally grateful we did March 1st. This was something in the planning, so we went to electronic records. We had electronic billing prior to that, but this has somewhat streamlined the process.
Virginia, would you even say too that using electronic records for most practices is really going to become practically essential?
Well, it was absolutely essential right now because, you know, the third week in March, everybody went to practicing from home, and for the most part has been practicing from home, and paper records were just not practical. I'm so glad we had planned on electronic records in the first place. Makes it possible for me to schedule my appointments. You know, I can point my clients in the direction of where to pay their bills. You know, it's been a year now, so we'll look and see how this whole thing has worked out. But anyways, I think currently we use an electronic records provider that allows us to create our own forms. So we were able to just basically take a lot of our own paper forms and make them electronic. So we didn't have to adapt to something else, some other system of record keeping. So that was really helpful.
I would add to that, you know, just in my experience of working closely with the insurance companies and watching trends, that, you know, there's no doubt that there will come a time when this is just really going to be a requirement.
Yeah, yeah, I think that may come down the pike. It is a requirement to do the electronic billing, though, isn't it, Jim?
Yes. Yeah.
Yeah.
Right.
Oh, next slide. So CPT codes. All medical services have corresponding CPT, current procedural terminology code. Behavioral health services have been assigned codes as well. These codes are standard across the industry and are used to submit claims to insurance entities. Psychotherapy codes, testing codes, health behavioral assessment and intervention codes. And I just will make a note, you know, I did not know anything about these codes until I went into private practice. I had worked in a hospital setting as my, you know, initially out of school. And so this was a sharp learning curve.
We would say that, you know, a good way of thinking about this is that every service a behavioral health professional provides needs to be translated into a CPT code in order for it to be billed to an insurance company. So that's just a good way of thinking about it. And the medical professions have been working within this system for a long time. And for those of us who are interacting with insurance companies, we have to sort of adapt to this whole system.
I will make mention of something I don't have a slide for, but I recently downloaded an app from the, I think it was the American Medical, or it might have been, I'm pretty sure. Anyways, there's an app, a CPT, on CPT codes. So I'm able to double check myself, am I using the right code? And it has a full description of all the codes. Normally in the past, we would be looking for this big, fat, thick book to, that would describe all this stuff. But now I have it right on my phone. So,
So we're going to add here that the essential CPT codes that most behavioral health professionals use are fewer than what would be used in the physical healthcare world.
yes,
So
absolutely.
we work with a smaller pool, and then you're going to kind of go through, and when everybody has a handout that sort of summarizes some of the main codes that are used, the vast majority of the codes that are used, and you're going to go through those.
Yes. Yeah. So I'm going to share a few of the slides. You're going to get more handouts than I may go over thoroughly, but I'll kind of explain as we go along. But all right. So for a majority of psychologists, psychotherapy codes are the ones you're going to be using most often. So the two psychotherapy codes you're going to be using the most often are the 90834, which is psychotherapy approximately 45 minutes with a patient. Technically speaking, it's going to 90834 is between 38 to 52 minutes long. You will be, as I will tell you later on, you will be actually marking the actual start time and the actual stop time so that you can calculate out that is the, it is a 90834, or like the next one is a 90837, which is 53 minutes or longer. So those are the two codes you're most likely to be using. There's a little bit of a controversy currently about 90837, although I think it's dying off, but insurance companies were saying that, people were, most people use 90834, but this is a way they can justify paying you less. So
we would say the important part for folks to remember with all of this is, and generally speaking, if you're doing a psychotherapy session individual for about 45 minutes, it's a 90834. And then if it's for 60 minutes, it's for 90837. That's just a good way of thinking about it.
Yeah. The other two codes I know I use because I do family work is 90847, which is family psychotherapy with a patient present. I've done a little recent digging on this. There is something in the description that really you need to be spending at least 26 minutes with the whole family together, or the family members together. 90847 is the family psychotherapy, but without the patient. That's about 50 minutes. So, oh, here they do have the time ranges here. So you can see that. There's a code, add-on code for interactive complexity, and I'll be honest, I don't use this very often, but probably should lately. This we won't be using unless they allow psychologists to prescribe here in Ohio. Psychotherapy for crisis. Unfortunately, in the past year, I've had to use this code more than I would like. 90839. It's the first 60 minutes of a crisis therapy session. Anyways, there's more details there. And if you want to find more information, again, you can go to the APA.
One of the things that we want to think about here with this is that these codes are standard across the industry. So in other words, insurance companies are not using different separate codes. All insurance companies follow these codes. And as I mentioned at the very beginning of our talk here, when we were talking about, contracting with insurance companies, not all insurance companies are going to cover all, services or all codes. And this is a part of what I was talking about. An individual insurance company may prohibit certain procedures or codes or say they're simply not covered.
All right. Well, so many psychologists do testing. A couple years ago, they changed the whole format. I'm not going to go into a lot of detail on this. And in fact, I believe there's another webinar in which we do go into more detail on this. But I will say that, so you can see there's quite a number of codes. Basically, they've devised a system where you get paid more for thinking, basically. So the time that you're spent, say, thinking about a case or reviewing test material, test results, or writing a report or giving feedback to a patient, all of that is paid at a higher rate, whereas test administration is paid at a lower rate. Although if the psychologist is doing the testing, it's still paid at a decent rate. Okay, here we have an example of record keeping for testing. So as I mentioned, you get paid more for thinking. These are going to be where you're recording all the thinking you do. So when you think about the case and what are the tests that you're going to give, that would be, you would, fill that in. That's date of service, the start time, the stop time, total time, and then the actual units that you're charging for. Decision making. So, maybe in the middle of the test setting, you decide to give another test. So that might be test review modification, or, some behavioral management that you have to do with the patient. Then the parts you're going to probably be using a lot would be record review, so reviewing history, integration of patient data, interpretation of the test results. All of these things fall under these two codes up here, 96130 for the first hour and 96131 for each additional hour. But I'm just kind of going over this a little bit to just kind of give you a brief overview of kind of what your you need to document So,
We would say, Virginia, that, a person who's doing testing would fill out this sheet that sort of documents the time that they spent on different activities. And then this would help them translate that into the codes that you were just showing us.
right.
And this is not meant to be an exhaustive training on how to do all of that. It's just to kind of get everybody's feet wet. And there are other trainings available from APA and other sources, a little bit more detail about how to use these codes and how to document.
All right. So here we have something that came out last year. These are called Health Behavior Assessment and Intervention Services, better known as HBAI services. So again, I'm not going to go over this really extensively, but I just want this is for when you're assessing a patient. For example, maybe you're treating them for pain, and so that would be the initial assessment would be 96156. And let me go down here for a second. Yeah. So, but what's nice now is they have the behavior intervention services. So then you start treating them from pain. The initial 30 minutes of treatment would be a 96158, and then you would charge for each additional 15 minutes. And then there's some other codes down here as well. I must admit, I'm not a health psychologist, so I don't use these codes very often. But if you are,
for us to consider would be that these are codes for assessment and intervention for behavioral change, helping a person to make behavioral changes associated with a physical health diagnosis. So when a person's having a physical health diagnosis, we want a psychologist involved to help them make some behavior changes to address that physical health problem. Then these codes would be used to help that psychologist or other behavioral health professional to assess and design and help to create an intervention for that problem. And we have in our OPA webinar library a much more detailed webinar on the use of these codes.
Yeah, so for example, if someone is treating, also another example would be, say, child or adolescent who has diabetes, and the family is having trouble with them being compliant with their diabetes treatment, and diet, so that might be an example of a case where you might want to use the HBAI codes. So, Leslie, do you use these codes very often? Because I know you do some kinds of assessments over there.
Yeah, so we use the HBAI codes for bariatric patients, for assessing them pre-surgery and for helping them make the necessary changes after surgery, and for pain management folks.
Thank you, Leslie. Record keeping guidelines. Each CPT code billed and reimbursed requires specific documentation in the client record. The documentation specifics are required by all insurance companies and are standard for the industry. These documentations guidelines in general tend to be more specific than record keeping standards in other places, such as state law or APA ethical standards, and are set by CMS. One of the things that the OPA Insurance Committee worked on a few years ago was coming up with an insurance audit toolkit. But this could also be used when you're starting off, because you could see all the things that an insurance company might ask you to have in your records. So that is a benefit if you are an OPA member. Otherwise, you can get it downloaded for $10. And obviously, it's something you can use for an audit if you get to there, but sometimes it's just better to prevent, not have to worry about an audit because you know you have everything they need in your records to start with. Okay, so what do you put in your records? You can see that, so this is a nice little fact sheet. It also has the CPT codes at the bottom. But in your record, one thing that you really, I always say, if nothing else, make sure you have a start and stop time. You have a location. So for example, I'm working from home. I have 2 locations noted in my records. One is the location of the patient, say home, and what service I'm providing. Is it via phone or via my video conferencing service? Also, you know, what kind of signs and symptoms they're having, brief description of at least 3 elements of their health condition. Just generally, I always have recommend things like, you know, sleeping and eating and energy. Those are good to document. So anyways, this is more about the time-based, as you could see, but that is, like I said, that's probably start and stop times. Make sure you're doing that. A little tip that I use and is now that I'm doing telehealth, I have a little pad of paper next to me and I have initials on it, date of service, and the start and stop times next to the initials. And then I actually write the CPT code then, and so I make sure I have that, and actually, because I'm doing telehealth right now, I also have a second computer in which I'm doing my electronic health records. When I'm in the office, though, I'm doing the electronic health records on my laptop, and but I still like to have that little pad of paper. So that I'm accurate when I'm doing my electronic health records. So I think down further on this handout, it goes into the documentation. So in the time elements, what modality and frequency you're doing. You know, is this individual psychotherapy? Is this family therapy? Is it every other week? So each note should have a diagnosis on it. The nice thing about electronic health records is you can get them, so that's just automatically printed on your, you know, on your page. You can also copy previous notes, just alter them so that, you know, you have all the standard things there, like goals and so symptoms, how they're doing functionally. I think also I include in there risk. I have a statement on risk that I like to do. Focused mental status exam, the treatment plan. So like I said, I always have the goals there, which is actually kind of helpful since I'm looking at my electronic health records as I'm doing therapy right now. It's nice because I can help to gear the session towards the goals. And then your name, your signature, and your credentials, you know, PhD, PsyD. There are some things that are currently going on right now. Oh, I should also mention, so that's the psychotherapy note. The initial code, which I didn't really go over that code earlier, but it's 90791. If you were a psychiatrist or a psychologist who prescribes medication, you would use 90792. But for those of you who are here in Ohio, you don't have to worry about that second code. So you document history, medical history, psychiatric history, any previous diagnoses or treatment, evaluation of the patient's ability to respond to treatment. You know, is the prognosis good or fair, excellent, and an initial plan of treatment, you know, see in 1 week or see in 2 weeks, you know, for family therapy or individual therapy.
These are the guidelines for documenting for that 90791, which is the initial diagnostic interview. That's
right.
Separate from the psychotherapy code. Psychotherapy code, you should be recording what was in that earlier box. And for the initial evaluation, you should be recording what's here.
Right.
Another thing that I would mention really quick about this is that this is a handout from CMS, the Center for Medicare and Medicaid Services. But most of the insurance companies follow the standard that is set by CMS. And so most of the insurance companies are going to want to see these kinds of things also, even though this says CMS. Most of the insurance companies are really following this, and they're going to want to see these things too. They actually might add a couple more things that they're looking for.
Yeah. But you know, if you're following these standards, you're probably doing pretty well, you know. And again, here's what you can use for interactive complexity. Like I said, I should probably be using this code more often. Patients with high anxiety, high reactivity that complicates care. So now you have an overview of CPT codes and, you know, the billing and the, not the billing aspect, that's the next part, but you've done your part, which is the CPT codes in your notes. And then if you're lucky, you don't have to do the billing yourself, but Leslie will tell you what to do if you had to.
Hi, everybody. I'm happy to be here today. And as Jim and Virginia have mentioned earlier, I'm the current chair of the insurance committee for OPA. And I'm also a group practice owner up in Portage County. And we bill Medicare, Medicaid, 10 or 15 different insurance companies, BWC, and employee assistance plans. So we have been through all of these things and these struggles ourselves. And I hope that I can teach you some things today and be a resource for you in the future with insurance questions. So the first slide we have up here is about HIPAA. And you may ask yourself, why are we talking about HIPAA during a presentation about insurance billing? And the answer is that as soon as you start billing insurance, which Virginia alluded to, most insurance companies require you to do that electronically now. As soon as you start billing insurance, you're transmitting patient health information electronically, and that makes you subject to HIPAA. You become what's called a covered entity under HIPAA. So theoretically, not all healthcare providers are covered entities if you're not transmitting electronic information electronically. But as soon as you are, then you're a covered entity, and you're covered under this federal law. The federal law was enacted in 1996, and the final ruling wasn't until 2003, but it really was for the purpose of recognizing that so much of our healthcare information was going to be transmitted electronically, and technology was just advancing very quickly, and we had to get a handle on what was a safe way to do all this. So I'm going to talk a little bit about HIPAA, but really, if you're starting a practice, you need to do a lot of training on HIPAA, and you need to probably have a HIPAA manual, either written by a professional organization or have an attorney who specializes in HIPAA help you with that, because it's pretty complex. So HIPAA basically covers how you're storing and transmitting all this patient health information, PHI. And it also covers the patient's rights to access that records and the steps that you have to take in responding to the patient's request. One thing I do want to note here is that HIPAA and state law and our ethics sometimes are in conflict or are a little bit different. And it's important to note that you really should be abiding by the highest standard of those three. So when there's a difference, abide by the highest standard. Another way to look at it is if one has a rule about it and the other one doesn't have a rule about it, you don't get off scot-free. You have to abide by the one that has a rule about it. A great example of this is, per HIPAA, we're actually allowed to exchange information about a patient with a referring doctor in order to facilitate care. But we know by Ohio law that there's special regulations that govern mental health law and substance abuse, or mental health information and substance abuse information and HIV status. So we can't always just say, oh, HIPAA says I can exchange whatever I want with the referring doctor. No, we have to look at the Ohio law and see that there might be additional regulations. So is there something you wanted to say about that, Jim? Yeah.
I just wanted to add real quick that an example of what you're saying would be that, if a behavioral health provider, releases unauthorized information to a physician, then that client would not be able to sort of complain to the federal government about, hey, there's a HIPAA violation here, but they certainly would be able to go to the Board of Psychology or the Board of, for the counselors and the social workers and say, hey, there's been a violation of my confidentiality. So it's just an example of how complex that can be and how all of that works.
Right. And I think just the word of warning is even if you have an attorney help you write your HIPAA manual, if they are a specialist in federal HIPAA law, but don't know Ohio state law as well, they may tell you something is fine for you to do when in fact it might not be. So you have to be aware of your ethics, the state law and the HIPAA law. Okay. Let's see. Let's move on to the next slide. Jim, can you move forward? So the next thing we're going to talk about are EOBs, explanation of benefits, and ERAs, electronic remittance advice. Jim's smiling because my billing person reminds me that ERAs are what the insurance company gives to us, as it says on the slide, and EOBs is what the insurance company gives to the patient. So
I call everything EOBs, and now I've been corrected.
Yep. So according to my billing person. So this is the communication the insurance company gives to you or the patient that explains how or why they are or are not paying the claim that you submitted. So this is really important to understand how to read these, because you can catch mistakes in either how you billed it, which resulted in the claim maybe being denied or underpaid, or a mistake in how they processed it, which might change how you're reimbursed as well. So it's important for you to be able to understand these and review these so you can check that your claims are being paid appropriately. So I am going to share an example of both with you here. Okay, so I've put an EOB up on the screen, an explanation of benefits, which again is the information that gets mailed to the patient to explain what their insurance company is doing with the claim that their provider has filed. And we can look at a couple things here on the EOB. You as the provider have billed whatever you're billing for this service, the CPT code, and the insurance company is coming back and saying that your contracted rate or the allowable amount for this CPT code is $102.69. And the patient's portion of what would be due, which could be a co-insurance percentage, a copay, a flat amount per session, or in this case, a deductible. So this patient might have a $5,000 deductible and they haven't met it yet for the year. So all of that money, the allowed amount, the patient is having to pay, and that's going towards that $5,000 deductible. So again, this is showing the date of service. It's showing the procedure code that you as the provider billed. It's showing what you as the provider billed as your full rate, and then what the insurance company allowed. So this is what your patient is going to get. So again, this is what the provider is going to get, usually through their electronic health record system. And the ERA may have multiple claims on it, not just one date of service and one patient. So you can see this one had four claims on it. And it's similar information presented in a little bit different format, but it shows the procedure that was billed. In this case, it was 4 90837s. It shows a modifier, and those are just special codes that tell unique circumstances. Like modifier 95 was that this service was provided via telehealth. You can see that we billed $185. That's our full fee for this service. Our contracted rate with whatever insurance company this is $109.59. None of these patients had a co-insurance. And you can see that all of this money went to their deductible. Now on the ERA, there's also little codes, and it tells you an explanation of what the codes are. And it tells you that this little code, this CO45, means that this extra amount, the $75.41, was above and beyond what our contracted rate is. So the insurance company is telling us that you billed $185, but only $109.59 is allowed. And this $75.41 is above and beyond what your contracted rate is. So you're not going to get that money. The provider's not. And you can't go back to the patient and get that money because you're an in-network provider. Okay. So again, the ERA comes sometimes even before our money comes. It's an electronic remittance advice. So the money is going to come in electronically, and this is explaining why the money is coming certain amounts.
Thanks, Leslie, for explaining that. And so I guess what I would add to that is that this understanding EOBs and ERAs is hugely important if you're in private practice, because it shows you so much about how the insurance companies are responding to your claims. And you can make sure when you become aware of what the information is saying, what the actual forms are saying, then you know things like, are they reimbursing you for the right rates? Are they even reimbursing you at all? Are they getting their copays right? And if there's a problem going on with your billing that the insurance company is not reading it right or falsely rejecting, then, which happens actually fairly often, then the ERA and those reason codes for any changes that they make or rejections that they make become enormously important. And then, of course, if you're a psychologist or a member of OPA, you can reach out to me for help with that. That's part of the services that we provide at OPA, support services for our members.
Good. So the last form that I'm going to talk about today is called the HIC 1500 form. And I have to admit, until today, HIC stood for, it's just a form that comes from the Healthcare Finance Administration. And this is their 1500 form, the form that we as providers use to submit our claims to insurance companies. And this is a standard form that every health insurance uses. So it's important for you to understand how it works if you're going to bill health insurance. I'm going to pull up a paper version of the form for you to see here. So many of you may have used a paper version of this form in the past if you were billing insurance companies through the mail. But now, since most of our claims are going through an electronic health record system, we're not actually inputting data directly into this form. We're putting data into our forms in our EHR, and the EHR is filling out this form for us and submitting it in the same format to the insurance companies. But it's still important to understand that this form with all these exact boxes is what the insurance companies are using to process our claims. And it's important to think like they're thinking. They're having a computer read this form and decide whether the claim is going to be paid or not. So they're going to look at your answers in these boxes, which have to be very precise, CPT codes and diagnostic codes, and your NPI number. They're looking at these things and matching them up to their computer program and deciding, is this claim going to be paid or not? So let's just look at a couple things that would need to be on this form. Obviously, all the patients' identifying information, name, date of birth, their insurance ID number, the person who is the insured person. So if you're seeing a child, this might be their parents' information, or sometimes it can be a spouse's information that's actually carrying the insurance. Also here, interesting to note in the middle, is the patient's condition, maybe their PTSD, is it related to an auto accident? Is it related to an incident that occurred at their workplace? And the reason that they're asking this is if the diagnosis is related to one of those things, the health insurance may not be covering it. They may be asking the auto insurance or BWC to cover it. So that's why they're asking these types of things. Down here, information about the actual service that you provided. They're going to be asking for the date of service and the actual ICD-10 diagnosis codes that you're treating. So the insurance companies don't use DSM diagnostic codes. They use ICD-10 diagnostic codes. And APA and different professional organizations have a nice crosswalk where if you're not sure what the ICD-10 code is, you can look up the DSM and it'll show you what the equivalent is, but they're often similar, to be honest. So you're putting the diagnoses in order of importance that you're treating here, the dates of service, where the service occurred, and then the procedures, those CPT codes, and if there's any modifiers like for telehealth and things like that. So again, the important thing is that this is getting fed into a computer at the insurance company, and the computer is matching up the provider's identity and the NPI number, which says what type of provider you are, a psychologist, a social worker, a counselor, and a marriage and family therapist. It's matching up what type of provider you are with what type of CPT code you're billing. Say you're billing for a psych testing code, and it's matching up the diagnosis. And sometimes the combination of those codes, the insurance company is going to spit them out. They may say, well, this provider is a IMFT, a marriage and family therapist, and maybe they're not allowed to bill this certain psych testing code. Or else they're saying this psych testing code can't be used with this diagnosis of ADHD. So again, this data is being used in combination by a computer to either approve and pay or to spit out the claim. So it's important for you to understand how that all works, and that this information you're putting on here is vitally important because the insurance company is not seeing your note, your clinical documentation. This is what they're seeing. This is their proof of what you did and who you are and all those things. So, okay. Jim, anything you want to add about a HCFA?
Just the main thing that is that, these are the basic paper forms that we all used to use back in the olden days. And those would be mailed in or faxed into the insurance company. Now we have electronic record systems, electronic billing systems, and they use the same, they require the same information, and it's in a slightly different format. The reason we're showing you this is to kind of get your feet wet and get you familiar with the basic essential information that needs to be collected that gets sent into the insurance company. So there's an electronic version of this that's slightly different, but it's still good to know this.
That's all the information I have about HCFAs and EOBs and ERAs and all those different letters. And I'm going to hand it back to Jim to move on with our next slide.
Okay, so finally, in closing here, I'd like to talk just a little bit about, what's happening right now at the professional association level for all of our behavioral health providers. So it's kind of helpful to know that, as professional associations, a big part of what we do is advocate for you in this area of interacting with insurance companies. So in Ohio, we're kind of a little bit right now on the cutting edge of trying some brand new things that I'm not seeing as much of in some other states. But right now, we actually have a coalition that we formed called the Behavioral Health Provider Coalition for Insurance Advocacy. This is a coalition that's including representatives from the professional associations of psychologists, social workers, counselors, psychiatrists, addiction counselors, and actually, I think right now at this point, nurse practitioners. So we've got reps coming from each one of these professional associations coming together. We meet once a month and we just talk about the concerns or problems that we have and being able to interact with insurance companies. And we're building our connection with the companies so that we are able to give them feedback about problems or concerns that we have. The important thing to remember with all of this is that because many of the insurance companies or entities that we interact with tend to be very large organizations or very large corporations, sometimes understanding or knowing the perspective of the providers ends up being the very last thing on their list of priorities. And so what we're doing right now is building this we're creating this coalition so that we can build better communication connections with the insurance companies to help them understand our perspective, how their decisions affect our ability to do practice, and just very specific problems or concerns that we have. This is our mission statement that you see right here. The Behavioral Health Provider Coalition for Insurance Advocacy strives to advocate for a more collaborative relationship with the insurance providers, assure adequate reimbursement, improve access to the full continuum of care using the expertise unique to the behavioral health services providers. And again, we deliberately put that last little part in there because we wanted them to understand that we hold an understanding and expertise that they might not always have access to. So that's our presentation. We hope that you find it was really helpful. I very much want to thank Dr. Leslie McClure, again, who's the head of our insurance committee, and Dr. Virginia Clark, who is our current OPA Vice President of Professional Practice. They're very knowledgeable about this whole area, and I want you to be able to feel free to reach out to them if you have questions or need some extra support. They can be great resources for you. This is my email address right here. My contact information can be especially useful for you if you are a psychologist and you are a member of OPA. I provide individual consultation. You can reach Dr. McClure or Dr. Clark. You can find their contact information on the OPA website, or you can also reach out directly to me and I can make sure I get information to them. So I want to thank everybody for your time today, and I appreciate you being a part of this, and we'll be having a question and answer session right after this.
Thank you, Dr. Broyles, Dr. Clark, and Dr. McClure for sharing your time and knowledge with us. Do you have a question you would like to ask the presenters? No problem. As part of OPA's 2021 convention, individual live virtual Q&A sessions have been scheduled for each workshop. All you need to do is mark your calendars and plan to join us virtually on the afternoon of Thursday, April 22nd, 2021 from 1 o'clock to 1:45. The Q&A session will be recorded and available for those who opt to view this webinar after April 2021. To receive CE credit for this webinar, please reference the document you received when you purchased the session. Use the links in the document to complete both the online webinar quiz and the evaluation form to receive credit. CE credit will only be given if a score of 80% or higher is achieved on the quiz. Should you have any questions regarding today's educational program or the CE process, please call the OPA office at 614-224-0034. Thank you again to our presenters and to our attendees for choosing OPA to meet your continuing education needs. That concludes today's educational program.